Hello, it's John Kanellopoulos from our center here in Athens, Greece, the LaserVision Ambulatory Surgery Center and Clinical Professor of Pathology at NYU Medical School, New York City, New York. This is a very interesting case. We inherited this patient after he had cross-linking in his right eye. These are the images now, quite advanced keratoconus. No Athens Protocol here. He had CXL elsewhere, and he felt that his vision was worse, although we're seeing his pre-treatment keratometries were worse than the ones we're seeing now. So this is typical for keratoconic patients, although the cornea appears to have flattened about two and a half diopters. This is the ICL calculation, and we're in the procedure now. We're going to do an ICL since this patient is best corrected with spectacles at 20 plus. So this is our go-to axis, 165 degrees, peribulbar anesthesia. And the most critical part in the central flow EVO ICLs, I'm so happy I can now use those in my US practice as well. We've had them for many years in Europe. I've actually remember implanting some of the first ones in Europe back in the late 90s, and it's remarkable that this lens has really survived many competitors, and it is now probably the only phakic IOL. So we're using it off-label in keratoconus, and the critical part is, and this is my own technique, it's not the traditional technique recommended by the company. I'll explain to you why. This is the toughest part of the procedure, opening the vial, and we're using the mosquito clamps. As I was mentioning before, the company recommendation is that you place the lens in the injector and you pull it through with a blunt special forceps, and you fold the lens with its backside down. I'm doing the opposite in my ICL, so I'm picking it up with a toothless forceps. I'm going to place it, and we've had viscoelastic in the cartridge, and I'm going to feed it in with a lens buckled with its optic side up and its haptics down. And I'm going to load it here very carefully, and it's very important to pull back and push again so you don't trap any of the trailing haptics. So we're going to go in with our 275 keratome. I need a little bit larger incision, a under millimeter paracentesis, so I'm going to enlarge this just a tiny bit because I need a little bit more room so I can insert the cartridge within the wound. Viscoelastic, and here we go, injecting the lens. And see now the lens, the haptic is on the top, and the optic is on the top, the haptics unfolded from the bottom outwards. Very easy to get in. I use a Kugelin hook to tuck the haptics under the iris. Successfully done. Center the lens, irrigation aspiration, especially through the central flow port of the lens in order to remove the viscoelastic from behind the lens. And of course, hydrate the wounds. They're going to be watertight, despite the fact they're about 3 millimeters, the major incision prosthesis under. I'm going to center the lens right on the axis, and of course use acetylcholine to attain meiosis. And the procedure is done. Actually, it's remarkable. The patient, as soon as he stood up from the OR bed, was 20/30, and within an hour before he left, he reached the 20/20 level with this remarkable phakic IOL intervention. This is John Kanellopoulos. I hope you found this presentation interesting. Signing out. Thanks so much for your attention.